Next, we're going to hear from Dr. LaidLaw, who is here to talk with us about the clinical data on treatments intended to change your sex. He is joining us remotely from California. And so thank you for you. It's a little bit earlier. So Dr. LaidLaw, you are recognized.
Thank you very much, Chair, and all. I have some slides that's saying I cannot share the content. I don't know if someone could correct that, or I could just start.
We're working on it, but members, if we want to get started, I could also move around if we think I should do that. But I do believe the slides are in your packets. So the folks in the audience can't see them, but if we're going to get started,
okay.
You have your, and we're working on it so that you can do that. Why don't we give them like 30 seconds to see if we can make it work, and then we'll start. So what does he need to do now? Can you try sharing your screen?
Here we go. I think that's.
Yep. There you go.
Okay. Can everyone see that?
Thank you, sir. Yes. Thank you, Dr.
Okay.
Dr. LaidLaw.
Thank you very much. And thank you. And thank you, Chair, and all for having me here. My name is Dr. Michael LaidLaw. I'm an endocrinologist practicing in Rockland, California for about the last 15 years in private practice. I've been looking into this area deeply for about the last 5 years and have written papers and have been an expert witness and given talks on this subject throughout that time. So I'd like to go through with you some of the medical consequences from this treatment. Being in endocrinology, we study glands and hormones. When hormone levels are very high, they can cause problems. We try to bring them back into balance. If hormone levels are very low, that causes various problems, and we try to bring those into balance. And what you'll see here is what they're doing with hormones is putting young people way out of balance. Just for some definitions, gender identity is the internal feeling of being a boy or a girl or some variation. Gender dysphoria is the discomfort that results from having a perceived gender that mismatched with the person's body, leads to significant distress and impairment lasting at least 6 months. Majority of these children, depending on what study you look at, but still the majority will grow out of this by adulthood, some 50 to 98%, depends where you're looking. So anytime we undergo any sort of treatment for a condition, we want to have a definite diagnosis. So if I want to treat diabetes, I want to make sure someone has a really high blood sugar. If we're going to treat cancer, we want a biopsy to prove that there's a cancer there to treat. How can we prove the gender identity? Can you find it on a scan, like a CT scan, or a brain biopsy or genetic testing? The answer is none of the above. There is no definite physical evidence of a gender identity, and therefore many kids will grow out of this and will be harmed if they undergo the treatments I'll describe. A bit of basic biology. There's only 2 human sexes. You can verify this by thinking of your own fertilized ovum. When you developed, there was a male sperm and a female egg that led to development. This proceeds on in embryology, where males and females are initially have similar tubules, but then there's a divergence, a split, with the males developing male-specific organs on one side and the females on the other. This happens very early in embryology, and the bridge cannot be crossed thereafter. There's 4 stages to gender affirmative therapy: social transition, or wearing clothes stereotypical of the opposite sex, or adopting mannerisms perhaps. Puberty blockers, which Dr. Biggs described very well, cross-sex hormones or opposite-sex hormones, and surgical modifications. Just to have a look at one good long-term study of Sweden, they looked at 30 years of data for 324 individuals who had hormones and completed surgery for transition. And over time, you can see here at year 0 to 30 years, survival rates dropped dramatically after 10 years for those who had transitioned. They also found that they had 3 times the rate of all-cause mortality and 3 times the rate of inpatient psychiatric care, and 19 times the rate of completed suicide compared to the population of Sweden. This is just showing what Dr. Biggs had described. Puberty blockers, this is the pituitary here, and these are the testes. They stop the normal communication between these organs, resulting in low testosterone for males, low estrogen for females. These are the normal, what we call Tanner stages of puberty, from early development to final adult development in males and females. And what the Endocrine Society is proposing is to block this very early on, Tanner stage 2. Why is this important? Because fertility is established around Tanner stage 4. So if they're blocked with puberty blockers and then take hormones and have surgeries, they will have infertility, and if they have surgical removal of their organs, they will be obviously sterilized. To move on to cross-sex hormones or opposite-sex hormones, to give you an idea, this is showing female adult testosterone levels. It's in a fairly narrow range from 10 to 50. Females do have some amount of testosterone, which we associate with males, but there is some smaller amount in females. In a common endocrine condition that I see, polycystic ovarian syndrome, it will be higher, say from the 40 to 150 range. With rare endocrine tumors, this will be much higher, say from 150 to 1,000. And these are dangerous tumors, which generally have to have surgery or other treatments. What are they proposing for hormones for this treatment is to bring levels to 300 to 1,000 level, which is on the order of these dangerous tumors that I described, and is some 6 to 100 times higher than endogenous female levels. What are the consequences on the body for that? To stay with females here, but females and males both have an increased risk of myocardial infarction and death due to cardiovascular disease, they found. Females will develop very high red blood cell counts, which is also a risk for heart disease. They can develop liver dysfunction, high blood pressure, various cancer risks of the ovary and breasts, hirsutism, which is hair growth all over the body in different portions, particularly the face and abdomen, a deepening of the voice, and both of those are permanent changes, sexual dysfunction and infertility. For males taking estrogen, again, these are very high doses of estrogen. There's a 5 times increased risk of thromboembolism or deadly blood clots. Gallstones, high triglycerides are possibilities. Breast cancer risk has been increased by 46 times, and also sexual dysfunction and infertility. What about going back to testosterone? High doses of testosterone have, in terms of psychological effects, have mainly been studied with anabolic steroid abuse. And what they found in those studies is that some 23% of subjects using these high doses met criteria for major mood syndromes such as mania or major depression, and even 8% or so developed psychotic symptoms. So it's a problem for the body and a problem for the mind to have these hormones so grossly out of the normal range. To move on to surgeries, referred to earlier as top surgery or mastectomy. This is a person who's natal female, born female. You can see the male growth pattern on the face we call hirsutism, and in the abdomen. And a surgical procedure has been done to remove the breasts. Complications from that, of course, the person will lose the ability to breastfeed. The woman will lose the ability to breastfeed. There can be significant scarring of 7 to 10 inches that can widen and cause problems, can cause pain, loss of normal nipple sensation, and difficulties with wound healing are possible complications. Just to emphasize, here's another study, 2018, I believe, showing how young patients around the country are getting the surgery. There were 2 13-year-olds who had mastectomies, 5 14-year-olds. You can see 15 and 16-year-olds. Professor Biggs had described the surgery. I won't go too much into it, but again, the problem with stopping a male at Tanner stage 2 is that they'll have a very undeveloped penis and scrotum area. Therefore, when the cavity is produced where the penis is inverted inside, there's not enough tissue, so a portion of colon needs to be attached to it, or there are other procedures which increase your risk and risk for multiple surgeries. Complications can include strictures of the urethra, infection, prolapse, fistulas, injury to the sensory nerves with partial or complete loss of erotic sensation. This is showing the phalloplasty, or the creation of a pseudo penis. A swath of tissue is taken from the forearm or thigh and rolled into the pseudo penis. This obviously can have very high rates of complication, as you might imagine. One study showed 76% had urethra fistulas or urethral strictures. Other complications could include infections like peritonitis. You'll obviously have large scarring to the forearm or thigh, possible injury to the sensory nerves. So what is the basis for this type of treatment? Who's making these rules or guidelines and such? The Endocrine Society, which I belong to and is otherwise does very good work, except in this area, produced clinical practice guidelines in 2017. I think you should know that 9 out of 10 of the persons who created these guidelines belong to the organization called WPATH, which is an advocacy group and is not a medical organization, though it has some medical doctors. So it's a very biased sample of physicians and others who created this document. They have in their disclaimer very clearly that this does not establish a standard of care. So if you hear it's a standard of care, they even said it isn't the standard of care. If you look at the grading of evidence, it's either low, very low quality, or there's no evidence for what they're doing. Now, the WPATH, which I just talked about, is an international organization. They create standards of care which really exist within their organization. It doesn't apply to anyone else and shouldn't apply to anyone else. And with this recent set, they actually lowered or removed the age minimums for surgery. So any of the things that I described and the other doctors described could be done at any age, which is obviously extremely dangerous, and children cannot consent to these procedures. They also removed all guidelines for minimum age of opposite sex hormones, in contradiction to the recommendation of their own expert consensus. So this is an extreme document, presents a grave danger to minors and should not be followed by any healthcare person in Florida or anywhere else, in my opinion. How can we help these kids? Well, they have high rates. Dr. Levine will, I'm sure, talk about comorbid psychological illnesses. These need to be treated and discovered. Perhaps they had physical, sexual abuse or autism, problems with, in the marriages or family problems due to divorce. These things need to be identified and properly treated by qualified psychologists, psychiatrists, counselors, and others who don't follow the WPATH model, individual counseling, family counseling. Just to emphasize, it's not a standard of care. We don't have the technology to make a male into a female or vice versa. Kids would not understand this. We don't know long-term outcomes, and what we do know for adults is not good. Medications are being used off-label, experimentally, and at high doses without proper FDA risk assessment profiles. Evidence quality is very low, as we said, and desisters and detransitioners have been ignored, though there are some studies showing the problems that they've had. Thank you very much for allowing me to present.
Thank you. I very much appreciate it. And again, look forward to questions. That was an excellent presentation. We're going to continue with our medical professionals. We're sort of hearing them all up front. We're now going to hear from Dr. Levine, who is the clinical professor of psychiatry at Case Western Reserve University, so he is not as far away. He's also joining us remotely. Dr. Levine, you are recognized.
Thank you very much.